I'd like to introduce Florence Dierzinski, who will be moderating the next session, highlighting a bunch of award-winning projects from OSSU that put patient engagement at the forefront. Florence is the president of University of Ottawa Institute of Mental Health Research at the Royal Ottawa Hospital. Florence.
Good afternoon. Bonjour à toutes et à tous. I'd like to invite the panel to join us. And so it really is a privilege and a pleasure for me to moderate this panel on strategic partnership to advance research. It's a topic that is near and dear to my heart, that's no doubt. But I know we stand between yourself and the rest of your day and the break, so we will be efficient today, and I'll keep my remark really short. What an amazing day. Congratulations to the whole OSSU team. Basanti, Dean, where is the team? I see John, Hilary, Caroline, and Eddie. Okay, you guys did a great job, and many of the board members were here around the day today, so that was really good. One of the most insightful sessions, I'm sure some of you would share my opinion, was certainly the retrospectives, like what's happened in the past 10 years. And the session with Maureen and Annette and Sandra and Alice was particularly insightful and grounding as well. I just would like to share with you a bit of update from the Royal Ottawa Hospital. So we specialized in mental health. Actually, we specialize in mental illness and addictions, let's say the words. And we have evolved our governance now we have now 2 patient partners who are voting members on our board. So they're my boss, and I think this makes total sense. So I just wanted to share with you the system is moving little by little. Okay, so really a testament today to the impact of OSSU, and I won't repeat how much the research environment has changed over the past 10 years, but what I would like to say, though, is that you're about to have 6 outstanding presentations around strategic partnership in research. It is really critical that we hear from our intervenants today their secret sauce around partnership, what made their skills and expertise made the projects a success. So I will call our first speaker, who is Andrew Pinto. He is the founding and current director of the Upstream Lab at St. Michael's Hospital. He holds the CHR Applied Public Chair in Upstream Prevention. Andrew, over to you.
Thanks so much. First, let me join many others in thanking OSSU and particularly Vasanthi for always being a strong support and encouraging us in our work that we do at the Upstream Lab. This is a project that I'm going to talk a bit about called Engage, which you can see from the title is focused on how do we actually engage particularly vulnerable groups in primary care. And particularly as governments across Canada are starting to invest more, and we just saw another announcement today from the Ontario government to expand access to 300,000 people who don't have access, how do we make sure that folks who are most vulnerable are actually taking advantage of that? Let's see if this will work. There we go. Okay, so the lab itself is about 9 years old now. It's a large team of 30 plus staff, and there are 4 of us scientists now, and our goal is actually to grow and to engage at least 1 new scientist each year. We also supervise quite a few graduate students and postdoctoral fellows, and at any time we have about 30 different projects happening. Many of them are with patient partners as part of the study team itself, or as advisors. Today, actually, I had to step away from the meeting because we had our quarterly advisory council meeting for the lab itself, which has patient partners from across Canada who are part of it. And our work that we do has a focus on diverse topics from artificial intelligence in healthcare to clinical trials to how do we evolve the primary care system. So as all of you are very familiar in Canada, about 1 in 6 Canadians doesn't have access to a primary care provider. And as I mentioned, groups that have been made vulnerable by social and economic policies are currently the most at risk of really finding challenging to access primary care. But also in fact, these new commitments of funds, actually, if we don't take actions, it will actually make things worse. And actually, both Nav and I work at the St. Mike's Family Health Team. We had this very good kind of example of this where we opened a brand new clinic, and despite our family health team's very strong commitment to equity, and even doing things like doing postcards and mail-outs to numerous social housing buildings, the new patients that came in that we found were actually from higher income backgrounds and the more well-off, because they're the ones who were able to hear about it, take advantage, and get in the door quickly. So with this, with Engage, our main objectives are first to evaluate novel ways in which across the country people have been working to actually engage people in primary care. And I think maybe the take home from this is also the idea of using adaptive platform trials to evaluate policy change. So this is maybe the heart of the new idea. I'll mention that part of why we brought this idea of evaluating policy changes, we've been running an adaptive platform trial in a very clinical context of studying treatments for acute COVID. And we're now thinking about applying this to other clinical topics. But the idea was, could we use this to study policy change? And so this is a project that we were very fortunate was funded by CIHR. And engages patient partners, health system leaders, and others in the work itself. And really, I'm just giving you the outline of what we're doing because we've completed parts of Objective 1, but we're actually just in the first kind of year of this work. So we actually have completed now a look across Canada of what policies have been used to engage people in primary care. And now we're engaging in interviews with health system leaders and also individuals who have struggled with accessing primary care from a number of provinces. Part of that is also talking to them and about would they be open to an adaptive platform trial to evaluate policy change. And so what we're starting with is in the Toronto region, we're using the Ontario Health boundary for Toronto, and it's already divided into 11 sub-regions. We've randomized 2 of them to be the intervention, 2 of them to be the control, and this is in collaboration with the Office of Health System Partnership, which is based at Department of Family Community Medicine at University of Toronto, and colleagues at Ontario Health. We're comparing a navigator to multilingual information, and we have this strong focus on connecting people who are already vulnerable to primary care. And yeah, that's kind of the goal of this. Again, I think the impact of this work would be, of course, to help us understand why are people falling through the cracks, what has failed with past strategies to engage people, to provide insights for policymakers, and also the findings of our pilot study are going to help us with actually sustaining a more national approach. But I think again, the main take home is imagine a system across Canada that we have set up, which is an adaptive platform trial to evaluate policy changes. That would be, I think, very powerful for a variety of reasons. And interestingly, it's been used in many low-income countries at a very high level to understand policy interventions, but it hasn't really been used in high-income countries to date. Great. And yeah, really we were successful with our CIHR grant with the support of OSSU. And they've also been very helpful in terms of engaging us in each of our meetings and also providing advice as things are moving into the manuscript stage. And thank you so much, and thanks for your time.
Thank you so very much, Andrew. I'm going to call now our next speaker, who is Lisa Hawk. Lisa is a staff scientist at the Center for Addiction and Mental Health campus.
Where are my slides? Oh. How do I do this? Is this slides?
Question closed. Good.
No, I don't know how to change my slides.
Good.
How do I change them here?
So they'll do
Okay.
Question and answer, which isn't a part of yours right
Right, okay. Sorry about that. So I'm here to talk about a project that I've had going. I have a small emerging research platform on the science of lived experience engagement. We've done some priority setting work to help identify those sticking points where we don't have all of the evidence yet. And we're moving forward on the priorities to work on that and establishing best practice guidelines for mental health and substance use research emerged as a priority. So I've been doing this with my team. This is a CIHR funded project. A shout out to my team listed that includes people with lived experience, family members, and some research staff and researchers. Next slide. So I'm going to give you, next slide please. I've got the clicker. It's this. Thank you. I'm going to give you a quick overview of the study itself and then talk a little bit about the results and then about OSSU's contributions to the project. So we conducted a lived experience engaged Delphi study to understand best practice guidelines for this sector. It was led by a lived experience advisory group that held 13 meetings throughout the process. For the Delphi, we recruited 35 people with lived experience, 26 researchers, so a sample of 61 expert panelists. There was a pretty diverse panel across disciplines in mental health, across Canada, and across ages. There were a majority of women, as we often see in engagement spaces. It was a 3-round Delphi study where we aimed for consensus. We built initial best practice guidelines based on synthesis of the literature and working together with our lived experience partners and based on our experience doing engagement, which we reduced through the Delphi process to 44 final items. Everything was rated on a Likert scale for importance and clarity, with consensus to find a 70% rating at 6 or 7. So through this, we ended up with 44 best practice guideline items. Here are some sample items that we can reflect on together. It was divided into several categories: an initial reflections and underlying values. We had 6 items. The first one talked about acknowledging that people with lived experience are experts who can inform research, make the research more relevant and improve its quality. This is a first reflection. If you're not on the right page on this one, you're at a high risk of going through with tokenistic engagement. So thinking about this and thinking about your engagement objectives authentically before moving forward is a best practice guideline. Under planning to engage people with lived experience, we have 12 best practice guidelines to guide people at this stage. An example is to start planning to engage as early as possible in the research project. We know that this is a sticking point in engagement. You can't engage until you get the funding, but you can't get the funding until you engage. So we just talk about engaging as soon as you're able to, based on the funding you have, and you can, whatever funding you can leverage to do this. Try not to wait until you're funded and REB approved and ready to go and everything is locked down. That's too late. So start as soon as you can, ideally at the priority setting stage. For onboarding people with lived experience, we have 7 items to talk about that onboarding process. An example is to take the time to establish friendly rapport and build relationships with people with lived experience. We know that building relationships is an investment in good quality engagement because then they're comfortable sharing their opinions. If you don't take that time to build engagement, you won't have authentic engagement throughout the process. 14 items for working with people with lived experience when the pedal hits the metal and we start really doing the work. How do we go about that? An example item is creating agendas and presentations that are clear, accessible, visual, jargon-free, and stigma-free. We've talked a little bit about acronyms today. Keep those acronyms to the minimum. Make sure things are clear. Think of accessibility beyond the physical accessibility, especially in the mental health sphere. Think about cognitive ability, the need to take breaks, the need to keep the reading level outside of that university level that we often see for lay summaries. thinking across the board about accessibility and, of course, stigma. Stigma plagues health overall, but especially mental health, and really making sure we're using people-first language that avoids stigma is important. And the last section is evaluating and reporting on lived experience engagement. We had 5 items. An example item is to make a plan to evaluate lived experience engagement and report on it. This is a gap in the literature. There aren't enough evaluations. We've talked about the PPEAT, which is a great one. There are a couple other great ones out there, but there is a lack and there's a ability to develop, and we are working on developing evaluations of engagement as part of our research platform. And how to report on it. Our team recently released some guidelines on how to report on lived experience engagement in a way that is authentic and reflexive of the engagement process that happened. So all of this happened with OSSU's support. OSSU was a knowledge user on the grant application. This grant application was funded at the first submission to CIHR. Anyone who's submitted to CIHR knows how hard it is to get a first round funding. We were just barely funded. We got a priority announcement, a SPOR priority announcement. And so it may be that the value add, that letter of support from OSSU was the value add that made the difference between getting funded and not getting funded to be able to do this work. So I'll be forever grateful for Visanthi, who's always writing me letters of support over and over again for these grants and is getting them through across the finish line. So it really demonstrated the importance of this project, of this line of work to OSSU and to the SPOR movement. OSSU also helped with recruitment. They put out our recruitment notice in the OSSU newsletter. They've got the participants that we're looking for following them, so that's important access. They reposted the recruitment materials on X. We did have a majority of participants from Ontario, in some part due to OSSU's support for our recruitment process. And with dissemination, they shot out the guidelines in the OSSU newsletter, reposted it on Twitter, X, sorry, and invited us today to highlight it. And I will share with you the final guidelines available in English and French, and there's also a manuscript presenting the full paper if you want to see that. Feel free to reach out if there's anything you're interested in this area. That's all I have. Thank you very much.
Thanks ever so much, Lisa. So many gems again in this presentation. I am delighted now to call Sarah Muntz. She is an implementation scientist at the Bloorview Research Institute. Welcome, Sarah.
Thank you. It's just, okay, great. Hi, as others have said, I just want to thank OSSU and Visanthi so much for your great support over the years and the opportunity to be on this panel today. Part of what we were asked to talk about was a bit of our path to how we landed on our particular project. So that's an element that I'm going to be highlighting today, which is a CIHR-funded project on developing the preferred components for co-design and research, or the precise guidelines. So I'll start here just to sort of set the context. This figure is absolutely staggering. It is from a BMJ article from 10 years ago that indicates that up to 85% of funding for medical research is wasted through non-publication, poor reporting, and poor design. And the authors put forward that a key contributor to this waste is that health research frequently addresses questions and outcomes that are of limited relevance to a variety of knowledge users, including clinicians, patients, and other key end users. So that obviously has a link or underscores the need for co-design. And when I sort of started on this path, and I'll talk about a particular study in particular that really sort of put me on this path, I wondered, like, what is co-design, right? Is it a methodology? Is it the methods? Is it the process? Is it the approach? I had all of these questions. as I spoke to more people, the idea of the principles in co-design really sort of bubbled to the surface. Later, I was asking, is it an intervention? So I really appreciated the question that came up from the last panel about that. So this is borrowed from a great article on co-design from Isabella Cawthorne, who talks about co-design washing. And what she meant by that was the use of sprinkling of co-terms without authentic evidence that co is actually occurring. And this graphic is from one of my favorite movies, Princess Bride. You keep using that word. I do not think it means what you think it means. So certainly very, very relevant when I was looking to the literature for, what are those great examples of co-design. So what is co-design? Of late, the work of K.A. McKercher has been really, really influential. As we've heard, from these past 1.5 days, co-design is designing with, not for, and K.A. McKercher says that it brings together lived experience, lived expertise, and professional experience to learn from each other and make things better by design. It also centers care. It values, prioritizes relationships, balances realism with idealism. Of course, we know that it can be quite a creative endeavor as well. And there's also a key piece around building or bridging capacity. So this is my journey. I'm not going to go into detail, but I did sort of tease that there was, one kind of key study that really led to that put me on this path, I'll say, and it was, I had concluded, one of my first grants as a independent investigator, and we did a co-design activity, and at the end of that co-design activity, we concluded, okay, we've got to co-design this transitional care intervention. We've got to co-design a peer navigation intervention. And this really is what led me on this path of exploring, well, what is co-design? How do we do it meaningfully? And my background is in KT, implementation science, so I have long partnered with community organizations, patients, and families. I'll certainly give a shout out to Ellen Tulaney, who I do a lot of work with in the space of youth and family engagement. We're really interested in the methods and approaches around youth and family engagement. So what the objective of this project, which is CIHR funded, we are wanting to co-develop the precise guidelines to enhance the consistency, transparency, and quality of reporting co-design studies used specifically to develop complex health interventions. And so our first part is we're doing a scoping review on the models, theories, frameworks used to co-design complex health interventions. We're looking at sort of their common elements. We're looking at values and principles, associated methods and methodologies, as well as outcomes. The second part of that work is some consensus work. So we've been going through a lot of articles, friends. So after removing duplicates, we started with about 30,000 articles, and we're currently wading through extraction on 143 articles. These are areas of extraction which our OSSU partners did help to inform. And so some observations so far from our extraction exercise. So certainly the indiscriminate use of models, theories, and frameworks, lack of reporting on principles and values despite their centrality. There's a lack of reporting on co-design outputs, a lack of reporting on remuneration, which I know a lot of people are talking about, and rightly so. A lack of reporting on training for patient partners, or not just patient partners, but other relevant partners. Use of design frameworks only without the co, and no research partnerships, no co, right? We're seeing a lot of articles where it's characterized as co-design, but it's a qualitative study, and they're talking about the perspectives from the participants of the study. I know I'm getting short on time, but what's the future? So in the short, the short future, we will co-produce these reporting guidelines, which I'm really excited about. We're really interested in the evaluation of the impact of co-design interventions. So do co-design interventions indeed produce better outcomes? Something I've been thinking about a lot of late is transactional versus transformational co-design. So not just about the app or the program that we develop, but what are the outcomes and the impact on the people that we partner with? The social outputs is something that we think about a lot. This again is from Kay McKercher about making co-design a reality, and in particular, I really I love sort of this whole vision, but I really appreciate the slowing down to listen, connect, and learn. And of course, my acknowledgements, a big thank you to OSSU. This beautiful quote from Katarina Davis that I've included here. My strength is not with me alone, it's the strength of many. Of course, I want to thank the partners with lived experience, the Precise Study team, including co-leads Carrie Koleski and Carolyn Steele-Gray, students, and a research associate that I work very closely with, Dorothy Leung. Thanks very much.
Thank you so very much, Sarah. I am now welcoming our next speaker, Christina Cocorella. She's an associate scientist for the Department of Medicine's Healthy Aging and Geriatrics program at Sinai Health.
Perfect. Thank you, everyone. So today I'm going to be talking a little bit about a study called Implementing a Novel Geriatric HIV Clinic in Toronto, Ontario. So for those of you who don't know, before I became an associate scientist in the department, I was the program manager in geriatrics. And my job was to essentially provide embedded support to our clinicians to find out what struggles are they happening, and then to use the research expertise I gave during my PhD training and then my postdoctoral training in implementation science to how do we better involve our models of care. Now, besides my research background, a lot of the work I was doing was actually out in the community. If you talk to any older adults, the last place they actually want to be is inside the hospital. And so really drawing upon the volunteer work I was doing in shelters, volunteer work I was doing at the Alzheimer's Society, a lot of my program of research was in dementia caregiving, I started to come across individuals living with HIV. And this was not planned. I was seeing them in the hallways of the hospital, oftentimes asking me where the infectious disease clinic was. They were in the shelters I was volunteering at, and even, yes, at the Alzheimer's Society. So I came to the hospital one day, and it was my turn to ask the clinicians the question. So I went to a geriatrician and I said, hey, do we actually see any patients living with HIV? To which they said, no, that's really weird. When I was doing my training in London, Ontario, we did. And here we are in Toronto, the biggest geriatric program in the country, and we're not seeing these patients. So of course, the researcher in me wanted to figure out why. So next time I was at my volunteering, just casually asked someone who was talking to me, okay, where do you go? What do you do? Where are you seeking help? Came back to the hospital, and with a brilliant team behind me, including individuals with lived experience, family caregivers, a team of clinicians, we started exploring the why. And so the researchers in the room are probably gasping at this point. I didn't have REB, I didn't have ethics, for those of you who don't know RB, and I didn't have funding. We were just chatting and kind of doing some things like this. And one of these individuals is in the room, Dean Valentine. And so I went to Dean and I said, we have a problem. I need funding to do this research, and we're going to start implementing a new clinic. And the way we did it is right from the get-go, we were honest. I talked about the rates of funding. I talked about that I can't promise what this clinic is going to do, but I did talk about, hey, I have a big team behind me. They really want to make this happen. We're going to try to get some funding. We're talking to the right people and administrators, and that's the point we started engaging OSSU. We knew that in developing this clinic, or in co-designing this new clinic, we wanted everything from the design, what services the geriatric clinicians would provide, to the social care providers we engaged in, to how we actually implemented the clinic to be clinically engaged. It sounds very ideal, but anyone who's ever tried to implement anything in one hospital system, let alone two, know that this took years to get to this point. But we did, and fortunately, thanks to OSSU's wonderful recommendations of support, we did get research funding so I could do my job, which at that point was as an associate scientist to start evaluating this clinic as the clinicians did their thing. And like any good researcher without money, we did a lot of scoping reviews. We tried to find the best practice evidence. Why would I reinvent the wheel? Well, no surprise, anyone in the HIV and geriatric space knows there is no model in clinic that partners geriatric care in an existing infectious disease clinic. So this is when we thought, wow, look at this opportunity. So the team kept growing, and I'm now fortunate to work with a huge advisory team that Dean leads, such that our program of research has expanded and continues to go and is patient-informed. Again, not an area I expected to be in, not an area I expected to work, but here's how we are. So thinking of OSSU today and the celebration that we're having, OSSU helped ensure that patient engagement was embedded in every stage, including their priorities to actually implement a new clinic, what this clinic would look like. They provided research frameworks and had this conversation with me as I was struggling with, hey, I'm talking to community that I'm already engaged in. These might be participants, they might not. I don't have ethics, what do we do? They provided guidance for our patient partners who we now involve in research. So these patient partners are analyzing data with us, they're collecting the data, they're informing our interview guides, they're listed on our REBs as co-investigators, they're on our publications as they wish. They provided guidance as to what's it like working with researchers. And I hope Dean says positive things, we're not all so bad. And they provided critical networking opportunities in the geriatric and HIV world. Hillary in particular was very honest in saying that HIV is not an area this group was well connected with. But they helped me navigate that, form new partnerships, and expand where I had started all this work, in community. So suddenly I was going out to mosques, I was meeting churches, community centers, other shelters, not just the AIDS organizations. So a big thank you for that. Now, this all sounds idealistic, but it was not without its challenges. I've had to go back to our committee of older adults living with HIV, and as much as they try to tell us what they want, and right now it's integrated care, I can't always make that happen. Research is very slow, but we're trying to get the word out there, even when I'm working with the people who can actually provide that frontline care. We have interactive co-design workshops, and again, these are co-designed. I don't set out what we're going to talk about in each section. And the big emphasis of our work is a culturally competent clinic. The community told us very early on that if we were designing a clinic, it was not going to be just a geriatric HIV clinic. We had to design a geriatric HIV culturally competent clinic. So that changes how we approach the funding. We budget for translators. We pay community as our stakeholders and as investigators. And we only host our events in very safe spaces. Again, these folks often do not come to the hospital. Luckily, and again through OSSU support, we've reached out to policy So the findings of our work now will inform a white paper with the National Institute on Aging to have that direct policy insight. Through that network, we've also been connected to policymakers, and we've recently been funded to create the HIV geriatric policy agenda. The policy recommendations will inform future HIV care in Canada. So we're trying to take our lessons learned in Toronto and move that beyond, and overall strengthening our partnerships. So the success of this work, and why I said, is the fact that the people who I engaged in early on, such as Dean and others, when I had no funding, no clinic, and no space, are still with me. They ride the waves. I've had to go more often than I wish to tell them we didn't win a grant or our paper was rejected, but they understand now, and they keep me going. We have now the partnering of policymakers and clinicians, and they feel empowered in their care. Recently, we just did our first arts-based study, which I was never trained to do, and that came from community. But as I said, this has been challenging. It's been a struggle to get clinicians outside of our Toronto network on board, and we've had to overcome power imbalances. I think this is the first time they would have seen me in a blazer. We try to match them, we try to empower them, but we still have that researcher, clinician, and patient level tensions that are very hard to break. We've had a lot of sensitive discussions around stigma, trauma-informed care, and had to go through this training. Thank you.
What an adventure, Christina. Thank you so much. Our next speaker is Christopher Canning. He is the Director of Research and Academics at the Waypoint Research Institute. Here you go, Christopher.
Thank you, Florence. How's everyone doing for the prime time 3:45 p.m. spot? Everyone good? Thanks for staying awake. And once again, my name is Christopher Canning. It's a delight to be here. Thank you to OSSU, your support, Visanti, and team for the letters of support, and I'll get back to that in a bit. So I'm really delighted to be here to share some of our team's work on supporting patient-oriented research in forensic mental health care settings. Our project began almost 2 years ago now with federal funding from the CIHR, with the goal of implementing POR practices in the high secure forensic programs at Waypoint, and creating tools for researchers, clinicians, patients interested in this kind of work. Now it's been a real team effort. A couple of my team members are here, Seville and Elnaz. They've been true champions of this work throughout. But among researchers, but most importantly among patient advocates, clinical staff, and forensic patients themselves, we've been really pleased to get forensic patients involved in our research projects. And you'll see other patient partners on the slide there. We've been working with the University of Saskatchewan, and of course with folks in the room here today. So I wanted to provide a quick thank you, obviously, to CIHR for the funding, and like I said, OSSU for the letters of support. I'll come back to that at the end of my presentation. So why does this work matter? We're working in a space where patient engagement in research is limited and in many cases non-existent. Patients live with serious mental illness and related disabilities. Their movement is heavily restricted, and institutional structures can create a lot of mistrust between patients and staff. Building equal partnerships takes intention, authenticity, and care. We've heard about this all day, about trust building and relationship building. It takes extra intention in restrictive environments. And yet we do this work because of ongoing calls for better person-centered care in forensic mental health care settings and those kind of approaches to forensic mental health care generally. Patients in these environments who are either involved in the criminal justice and forensic mental health system face layered stigma and discrimination for their involvement in these systems. But yet that's precisely why we do this work. In places where choice is limited, we believe that authentic engagement can be a powerful transformative act for everyone involved. So over the last few years, we've been putting together our study. We've been doing some qualitative work to support our organization and others in doing this. So using an integrated knowledge translation approach, we began with a qualitative readiness assessment, looking at the barriers and facilitators of doing this kind of work at Waypoint, specifically with mentorship from the University of Saskatchewan. That included conducting interviews with both patients and staff, and those findings were recently published in Frontiers, and there's a QR code at the end if you're interested in checking that out. Now, at the heart of it, and again, we heard this all day, it's kind of neat being at the end of the day where I've heard this so many times, trust and relationship building is at the heart of our work. We wouldn't do this work if it wasn't about trust and relationships. So over the last 18 months or so, we've been building trust with patients and staff, and this has taken a lot of work among all of these stakeholder groups. And we recently published a commentary about this process, about our relationship building process, and one of our patient partners, who is a current forensic patient at the hospital, is one of the co-authors on that paper, and we're really proud to have involved a patient involved in that paper. So that groundwork made it possible for us to host a knowledge sharing event last year where we brought together various stakeholders, patients, staff, external partners, to talk about what it might take to make patient-oriented research a reality at Waypoint. We also launched a community of practice with other researchers doing participatory work in forensic settings. And this is what we found. Trust takes time. We've heard about this all day as well. Patients in secure care often face systemic mistrust, making relationship building infinitely more complex. Power dynamics run deep. Legal, clinical, and security oversight shapes every interaction. So navigating those takes extra care and caution. And context is everything. We heard a bunch about context today. But standard POR models don't often account for security, restrictions, risk protocols, and involuntary treatment. And voices are often silenced. Forensic patients are rarely seen as knowledge holders, and epistemic runs deep. I appreciated earlier hearing about epistemologies and the importance of different kinds of knowledges at the table. And finally, support must be specialized. Training needs to address the unique constraints of these environments. Man, that clock goes fast, doesn't it? Okay, so what do we do with all this? Building on the work that Lisa Hawk does, and Lisa, your work is going into helping our work, and we appreciate it. We're developing a forensic patient-oriented toolkit under these 5 dimensions: training and resources, confidentiality, consent, and compensation, relationship building and shared understanding, levels of engagement. We heard about that earlier, that we can't go all the way to power sharing, and especially in forensic environment, power sharing, I think, is actually impossible. So we have to figure out what levels of engagement look like in those kind of environments. And of course, we heard a lot about this evaluation and sustainability of projects. So we also know that there's a lot of toolkits out there, so we don't want to contribute just another toolkit to the work, but we want to adapt this to our forensic environment, and that's why we're doing what we're doing. And so I just want you to take a look at some of the impact quotes here from the patients. All of these guys have been involved in our work either through our knowledge translation events, through our publications, and through some of our interviews. Take a moment to read through those if you don't mind. And in my opinion, they speak to the real impact of our work and keep us motivated around why we do what we do. They talk to a sense of belonging, the freedom to speak openly, the feeling of being heard, respected, and valued. And that's the kind of stuff that keeps us going. Okay, next steps, finalizing the toolkit. Then we're going to continue to build the connections and the relationships that are needed within the hospital, beyond the hospital, and internationally, as I said, with our community of practice. And we have a project just about to start where we're going to use the toolkit pieces and put this into play in a forensic environment. So thank you so much for having me today. It's honestly a true pleasure to be invited to these events. I wanted to thank OSSU for connecting us to people, for supporting our work, for writing us letters, to helping us mobilize our work, and being invited to situations like this. So thanks again. Scan the QR code if you're interested in any of our products and tools, and thanks again for having me.
Thank you for this fabulous work, Christopher. And then our next speaker is George Fusias. He is the Chief of Schizophrenia Division at CAMH.
Thank you very much. I couldn't start off a slide without inundating you with CAMH purple. So there's CAMH purple for you. I didn't wear my purple shirt. I left it at home today, but next time I'm invited back. So I realize that I'm keeping everybody from the wine and cheese, so I'll keep this punchy. First off, to thank OSSU for inviting us back. My colleague Aristotle Voineskos had been here a couple of years ago, and I get to share some of the updates with you as well. So this study is called EPISET, so Early Psychosis Intervention, Spreading Evidence-Based Treatment. And I'll take you on a bit of a journey of some research that then has helped shape policy and some exciting work that's happening in our province. Oh, I should say I don't have any disclosures. I am the Provincial Clinical Lead at the Center for Addiction, at the Mental Health and Addictions Center of Excellence, but no industry conflicts. This works. And in summary, for those that don't know, a first episode of psychosis is probably one of the most disabling and frightening experiences a young individual can have, and their family or care partners. This usually starts in teens, 20s, and early 30s for the vast majority of people who are going to then develop a psychotic disorder, and it really disrupts their lives, and is also linked to an increased risk of mortality, all-cause mortality, 10, 15-fold higher than the general population. What we also know is that early psychosis intervention can be life-saving. That folks that get access to care and get access to high-quality care do better. They do better for longer, and it reduces their all-cause mortality. Despite that, recovery rates continue to be low, and psychotic disorders, including schizophrenia and mood disorders with psychosis, continue to be incredibly disabling. And one of the major challenges has been the inconsistent delivery of high-quality care in the context of early psychosis programs. And in Ontario, we're fortunate. We've had for many, many years now a network of early psychosis intervention programs. There's almost 50 across the province, and early psychosis intervention standards that have been in place since 2011. Despite that, there's huge variability across programs in terms of the kind of care that they provide, and in particular, not so much the medication that's prescribed or whether or not someone is there to put out fires and do case management and crisis intervention, but about the recovery-focused work that needs to happen, getting people back to school, getting people back to work, and supporting families. Those areas are the areas that is highly inconsistent across the province. And there's been requests from teams to help have manualized approaches to care, to have more time for training, and for training on the latest evidence-based care, and also a community of practice to support them in delivering the care that these teams want to deliver. And so with those challenges in mind, we went forward in late 2018. I think it started between Christmas and New Year's that year, based on a very short turnaround time for CIHR for an innovative clinical trials application, with support from OSSU and a number of other partners, including people with lived experience, to put together an application to address some of those challenges. And we were fortunate to get funded, and the goal here was really to take an evidence-based model of care that had emerged out of some National Institute of Mental Health funding in the US, implemented in 6 diverse settings, not CAMH, but other places: Thunder Bay, North Bay, Lake Ridge, Waterloo, Wellington, Sudbury, and Niagara. So really diverse settings across the province, and look at whether or not implementing that model of care can improve fidelity to EPI standards and enable more consistent delivery of care, as well as improving both patient-level and system-level outcomes, and through this process to meaningfully engage people with lived experience and their families and care partners in this process. And around that, to build a community of practice for delivering high-quality early psychosis care. And so we started off by engaging youth and peer support workers and family members right from the outset, embedded that work in everything that we did from that point forward, both in designing the proposal and setting the priorities for what we needed to achieve based on what they were identifying as their major challenges, and then in every other component of this sort of multi-pronged project, ensuring that both patients and family members were engaged and contributing to setting what the priorities were, helping design sort of recruitment approaches, helping with our language and the clinical team's language around how we talk to people about what this is about, what for the clinical teams and for the patients coming through the doors, designing qualitative interview guides, supporting implementation, and then also leading some knowledge translation activities. So what you see there's a photo of Augustina and Lillian, who have been our leads for our advisory groups. Some of you may know Lillian and Augustina. They have presented some of this work not only locally but nationally and internationally, and a lot of excitement from other people to engage them in how they've been doing this work and to learn from that. And both Lillian and Augustina have been not only leading those advisory groups but also sit on our weekly steering committee meeting. And so they meet with us, and then we go to their advisories as well to make sure that we have regular touch points to the discussion around relationships, and being able to learn from them. And we've also been evaluating their engagement using the PPEAT, and that's one of the sort of the early kind of inputs from OSSU in helping us think through how we engage people early on and shape the evaluation and structuring that, and making sure that we're addressing areas of growth that the youth and families are asking us for. And then in addition to that, we've also, I'm quickly running out of time, just to highlight, we've trained a ton of people, so over 180 clinicians. Through this project now, we're just wrapping up. Over 1,300 youth have received this new model of care across the province. We've shown some improvement in fidelity to EPI standards, some early wins, particularly in those recovery-oriented components of care and the bringing together of a team, as well as some improvement in functioning, because I'm a researcher, I also want to measure functioning and symptoms. And then we've also built this community of practice using Project ECHO that some of you may be familiar with. We launched this virtual community of practice back in August of 2019. Some stats there, we run this twice a month, 95 sessions so far since 2019. 139 registered participants, and a continuous evaluation of their value and their satisfaction and engagement with that process as well. And what's notable is that we have family members from our advisory who also sit as part of the ECHO Hub team as well. And then I will close with some final pieces that I'm really proud of. Not only a website that is a knowledge hub for folks across the province, but we've had our family members and youth support us in building up digital tools for this manual, both for synchronous and asynchronous care, helping us. This happened during the pandemic. Everybody remembers that terrible time. And so we had to quickly pivot to supporting digital care. We worked with our advisory groups to build out some toolkits on how to support patients and their families and clinical teams. The families themselves developed a learning series for family members being able to speak to other family members about the experience of psychosis and how to support their loved one. That's now live on YouTube. And then finally, all of this work helped shape the provincial early psychosis program through the Center of Excellence, and has been some of the local evidence that's shaped what the model of care is going to be for the province going forward, with our family advisors and youth advisors actually being part of those groups through the ministry as well. So we're super proud of all of that. And a huge thank you. There's more people than are on this slide, but huge thank you to OSSU for all of the support. John, who's been at all of these meetings with us as well, and a whole host of other people. Thanks, everybody.
Thank you very much, George. This is so impressive, and I wish we had like an hour per talk to be able to dive in, but I know you have online resources and that we can contact you afterwards. Oh, by the way, I think CAMH has the best motto, mental health is health. So here you go. So, I have to apologize. We are basically running 19 minutes late, and so I will encourage you to interact with our speaker during the networking session. Please help me in thanking our speakers today. You guys are such experts. You are such experts. You make it look easy, but we know it's not. It's courageous work, so thank you.